perhaps you should.
Sunny's presentation. Thanks so much, Sunny. Sunny is from the University of Zambia and Mid Africa, and is about to present on this topic. Thank you.
Thank you very much, Corinne, and good morning, good afternoon, everyone, depending on where you are. So I'll be talking about COVID-19 in relation to stories or narratives that some of the people here in Zambia who are living with HIV went through, especially during the peak of the pandemic. So just a brief background to this study. So the study was conducted between 2019 and 2020 with some funding from the BA and University of East London Global Challenge Research Fund. It was a study that was done across, I think, 4 countries, but of course using different approaches and areas of focus, but generally also just following up on narratives that relate to COVID. So in May and June of 2020, we did some follow-up interviews with 20 participants in Zambia, 10 males and 10 females, particularly those that were living with HIV, on how COVID-19 has sort of affected their lives. Their findings were analyzed using some thematic approach by focusing on the negative effects or aspects of COVID on their health, the social space, but also more importantly, their mental health, as well as material resources. We were also interested in understanding how the post-COVID era will look like, especially for those people that are living with HIV. Now, Zambia is relatively a small country in terms of population, and we experienced high mortality COVID-related rates, and we had over 300,000 COVID cases as of 3rd June 2023. So how did we conduct this narrative approach in understanding the experiences of our participants who are living with HIV during the COVID pandemic? We were very careful in the selection criteria, so we adhered to ethics. For example, we ensured that the discussions or the dialogue between the researchers and the participants was empowering in some form. And as you might be aware, there was a lot of social isolation, but conducting this study via the phone was helpful and created a sense of collectiveness for some participants. So the data was more on stories that participants were interested in telling us. So this idea of telling was very key. It was more of us listening to them, narrating the experiences, but also more importantly, we were interested in the gender divide for people that are living with HIV within the context of how they experienced COVID. Theoretically, the framework that guided this study was therapeutic citizenship and this idea of decoloniality. As you might be aware, Zambia, just like many other countries, are dependent on donor aid. So experiences of COVID in relation to decoloniality of resources, especially within the health sector, was very key in these discussions. Again, we followed a narrative thematic analysis in understanding some of the stories that were given. Now, the focus really was on what was being said, the content of what was being said in these stories or narratives of the participants. And this content was really grounded in us understanding their own subjectivities and agency in dealing with some of the negative effects of COVID. So again, the focus was much more aligned to what sort of meanings do we draw from these tellings. I think the idea was to put the narrator in the central position of looking at what possibilities are created as a result of this overlap or interrelationship between having to live with HIV within a new pandemic, which was COVID at the time. But more importantly is the issue of social identity. What does this mean for group belonging and collective action, particularly based on previous works that have been done in looking at how citizenship that relates to HIV has been very strong over the years, but with the disruption of a new pandemic, how this was being sustained was of interest. But in relation to issues of inequalities and the power overlaps that our participants were interested in, we explored these narratives, the common narratives across the transcripts or across the stories that we were getting. So we were coding these inequalities as experienced by participants. So I've got two cases with me. The first case that I want to draw attention to is from Siwo, which is a pseudonym, and she's 52. And she talked about the issue of time, that now during the COVID pandemic, it was very difficult to access medicine from the health facilities. So there was rationing of ART, antiretroviral treatment drugs, for people that are living with HIV during the COVID pandemic, as so many spaces were closed down. So it meant that one would only get medicine after after 6 months. And in some cases, we got stories of people having to take drugs that were expired. So it became very difficult to access the health facilities. So the issue of temporality then plays a role in understanding how some of our participants experienced COVID. But within this story, something else that we see is the issue of language and space, that there are spaces that were, how safe is a space that were a no-go area. We see also within this story the issue of resource diversion, that there was a sense of worry among some participants that the resources were being diverted, or there was a lot more effort that was being put on COVID as opposed to HIV. So priority and resource diversion was very common in all the responses and the stories. I'll move on to the second case, which is also very similar to the first one, but a little bit different, because this second case speaks to how physicians also became very difficult to access. So it wasn't just the issue of medicine, but it was also the issue of the health personnel within facilities that were difficult to get hold of. But in all this, we see a sense of government being at the center or central place of taking control of the situation. So there's a positive side of things, that government showed a level of commitment in dealing with the situation. But also within this second case, we see the issue of mental health and psychological issues being very common, that now people are afraid of having to go to the health facilities. We see that people were worried or stressed with issues of resources. We see how governments can play a role in controlling citizens, especially when there's a public health crisis. So what do we make of these cases? Basically, the first point here is that we got these stories with a sense of positivity in terms of how people with HIV were still desiring to continue their treatment, but also the issue of testing. We also had issues around family and friends being supportive, NGOs coming in to help out. So those a positive element that for people that were living with HIV, there were some systems or individuals, even institutions that were still supportive. The second point relates to how difficult life became. People lost their jobs, issues of food, transport, poverty, because most of them have to move from one point to the other in terms of distance to access their treatment or drugs. So this was a very difficult time for most of them. Then the issue of looking forward in the future, those are possibilities that, there was hope for a better education, jobs, and businesses being resuscitated in a way. Now, within all the stories, I think there was a level of inequality or inequalities that we can identify that, the experiences within these narrations were overlapping, and to some level, inequalities were being experienced at different, stages and different levels. So participants, to some degree, cited some of the measures that they were dealing with, or measures that they came up with in trying to reduce the effects of COVID as it relates to those that are living on ARA team. So stories were multifaceted, and I think it was very interesting to see a thread that passed through all the stories, because within these stories, there was a sense of distress, there was a sense of fear, but also that of hope, particularly drawing from the experiences of how to deal with pandemics such as HIV in the earlier years of the outbreak, particularly in Zambia in the 1990s. So some of those lessons were used to deal with COVID. Within this, I think it's the issue of health inequalities being worsened by the issues of drugs, stocking of drugs, and also that there were a lot of difficulties for people that are HIV positive, because there was a sense of fear among them that if you've got an existing condition such as HIV, then you become more susceptible to the COVID virus. So I saw within the text that there were also economic inequalities that related to issues of work, that it was very difficult. Like I mentioned earlier, people became homeless, and destitution was very high from these stories. Mental health issues, yes, because then the fear of being at the clinic, isolation, societies here in Zambia, just like many other places, are built around social bonds and a sense of belonging. But then with the government restrictions of reducing on numbers of gatherings and not being seen in groups to avoid spreading of the COVID virus, acted as a linchpin through which these participants felt like they were more distressed because they had no one to talk to. The technological gap, now everything was online. People moved, digitalization sort of isolated so many people. Some of them don't have access to the internet, or they don't even have smartphones. In a way, there was some resistance to this inequality, to some of the inequalities that were being raised, especially those that were not systemic, that there was support from family, like I mentioned, NGOs, including the government, was helping. But also looking forward into the COVID, the post-COVID era, that people were not very convinced that the government can handle pandemics, given that there's a lot of disruption in life, and the economic issues were very much at the hem of this lack of trust within the government circles. So what are my final reflections then? From our findings, we can tell that narrations of COVID experiences as it relates to those that are HIV positive should be seen within the context of not having fixed representations, and also the issue of vulnerability, particularly where poverty is in the picture when we are discussing HIV-related issues against another pandemic, in this case, COVID. And more importantly, it's the social and historical context of the research that we need to look at the history and the legacies of HIV and how they play out into a new pandemic. And this was very clear in the narrations or stories of our participants. We need to think about not just getting these stories, but going beyond the words that were being given, like in the two cases that I've illustrated in my presentation. So there's an overlap or an intersection of themes, that some of the issues really played along, from the social, and then they got onto the economic constructions within the issues that really had to do with inequalities that played a role on some of the negative experiences in terms of the health, the economic, the social. All of these issues were really overlapping. All in all, I think there's an opportunity to dignify some of these experiences that people went through stories and listening, and just having this idea of telling was in a way dignifying for them, and it was empowering. Thank you so much.
Thank you so much, Sunny. I think that's great. Some of those themes will probably come back in some of the other presentations as well, I think. So great start. Then the next contributor is from Federal University of Bahia, Adriana Prates, and she's going to talk about her work in Brazil. Thank you, Adriana, for being here at 2 in the morning.
Yeah. Can you see the screen?
Yeah.
Okay. Asked about the effects of the pandemic in the research to live in HIV. The main topics that emerged from the interviews were about economic issues and the lack of psychosocial and health support by the HIV health services, and mental health issues. And besides some comparisons, an interesting topic that appeared was the use of the experience about living with HIV for a long time to understand and deal with the COVID pandemic. The participants faced the new pandemic with the obsession for the origin of the disease and the stigmatization of a specific people community was bigger than a search for healing, as happened with HIV at the beginning. Here in Brazil, we have the main authorities of the country are negationists and discourage lockdown, discourage the use of masks, and recommend treatment with no efficacy, medication without efficacy, and didn't buy the vaccine as soon as it was available. And even came to say, the president of Brazil even came to say that the vaccine was related to increase in AIDS. So it was an extra insecurity that we Brazilians have to deal. And we have 700,000 of that here. So continues, some participants are activists for a long time. Decades ago, they fight for treatment, for rights for people with HIV, against the stigma, and so on. And the lessons from this activism were used to provide some support, mental health support, psychosocial support to each other. Some of them received and gave support to peers in form of phone conversations, WhatsApp groups, donations, help to get benefits or aid, and so on, as we'll see ahead. Another similarity pointed by some participants was about the way COVID-19 was portrayed. As participant 24 says, as an illness that affects people with a weak immune system, in this case, the elderly. The youngest had a better immune system, so in her opinion, the COVID-19 was explained totally different, and it was also shown in a discriminatory manner. That is saying that the elderly will die, but the younger ones will not die. The information COVID was shown in the complete wrong way and showed prejudicially. About economics, the majority of participants were very poor people. For some, the situation worsened since they used it to make a living doing odd jobs, for example. People that didn't have benefits were in deep needs, and some were dependent on charity. About it, participants to say, well, I have been doing what's necessary to survive, right? I have had some support from Conceição Macedo, that is an NGO, who gave me food parcels, and the school of my daughter also gave me food parcels, right? She continues saying that the HIV made a comparison. The HIV did not disrupt the global economy, was the COVID-19 impacted negatively the global economy, to the point where I will tell you, I went through some financial hardship. I'm still going through some necessity at the moment. I'm using alcohol to cook. And I want to go out and sell some products, but I cannot because the local authorities are stopping us from working. Go to the street to do some work in order to bring food for the house. And about health support, people were desolated because the service is only open to provided medication and no other help or assistance. And participant 13 say we can only pick up the medication, but if we need the medical center for something else, we can't. Another participant say at the moment I cannot get any appointment with my regular doctors, such as infectious disease doctor and clinical doctors. I do not have any monitoring or medical follow-up at the moment. There are not many appointments available at the moment, and I feel as if they abandoned me. And about the mental health, the insecurities about there are insecurities about if people living with HIV were more vulnerable to get COVID. And these worries were intersected with worries about lack of health assistance that I mentioned, nah? And bringing bad feelings. So the participant 16 said, by adding together the group of risk, I would be in the group that would be worst affected. You know, it is virus, for example. My son got it and he doesn't have any illness. It was easier for him, but in my case, it will be different. I feel very scared because people like me have less chance to recover from it. The participant 16 told a story. They advised me that it was not an emergency. There were some marks on my skin. The pharmacist was the one who gave me medical advice to use a shampoo anti-dandruff to treat my skin infection. But the treatment is not working, as I still have head marks on my skin. Only when you look closer, you can notice them. Not here at home have noticed them, the skin marks. But let's not tell them. The doctor told me that she would see me when she was back, but we know that they will not offer us any new appointment anytime soon. And she continues, I'm not sure if it's something bad and I haven't run them yet to check. I'm praying to God that it's not something bad. I still have some medical tests to hand in and the results come up on the 19th. I have to collect them, but no one hang me yet. And also because of this pandemic, I know that there are no appointments at the moment. Yes. The narrative of the HI values e HI values. This expression was a kind of internal joke between some participants. Velho or velha, velho in case of man or velha in case of a woman means old. HI velho, HI velha means something like someone who has been living with HIV for a long time. Some of them created the expression since they have been living a long time with HIV, so they use the terms to refer to themselves. And so many participants of the research became HIV positive in the 90s. Some discovered that had the condition when they were hospitalized with AIDS, long before the advent of active treatment. From then, many became activists, fought for health rights, were provided with support by their peers, and they founded an NGO, and were present at the foundation of official institutions in the city. You know? They knew a great deal about HIV and politics, and expressed how protective it is to stay together and act together at the pandemic time. So some of them at the interviews said some things, expressed their worries about the peers, and they tried to help. Like Jay said, who got COVID, say that HIV activists he knew helped him, giving him phone support. Eddie mentioned his worries about some colleagues who were in need because they were unemployed or were informal sector workers. Marina's friends were in touch by phone, giving each other strength. Nelio expressed worries about his HIV positive friends who were in need. Olympia mentioned her 3 close friends also living with HIV who gave each other support by phone and internet. Dulcie received strength from HIV-specific WhatsApp groups and supported other colleagues. Janet mentioned her friend supports as a personal resource. So the story of this group showed the search of being together as people living with HIV. They were experienced, they knew a lot about going through hard times. They had learned to share and benefit from this experience and to communicate and intensify that learning narratively. Professor Ruby says, now a friend of ours who is part of the RNP, that is a national network, has arranged some masks and left some at SEDAP, that is a health service. I have to get it to them. And asked how he got information about the pandemic since the service didn't provide. He said, I am receiving news from the RNP group, the Positive Life, and from the States Council. Cleo, that is in your own words, a Gaivela, since she lives since 1998 with HIV, she said, I am fortunate enough to have met people that helped me through the difficulties and showed me that we could live with HIV and life carries on. So time was passing, I had a few birthdays, and I become an elderly woman with HIV, uma HIV. I am HIV positive, but I am still here and well. Thank you, thank God. Also thanks to this internal force, but this internal force is ours. We are the ones who bring this force. I'm prepared for this disease or indeed for any other disease. And as final reflection, I'll say that the main Brazilian findings were about economic needs, mental health issues, lack of assistance, and insecurities about if the HIV represented more vulnerability to COVID. Besides, they made critical associations between COVID pandemic and the HIV pandemic, like difference between impacted economy, obsession for the origin of the pandemic, and the stigmatization of groups of people. The lessons and experience from activism were used to deal with insecurities and provide support between peers. Thank you.
Thank you so much, Adriana. Thanks so much for that. I think, many of the themes are quite similar coming out of these studies that we did. And we are gonna probably see something similar in at least my presentation. Do you think you could stop screen sharing, Adriana, and then we could go on to the next one?
Okay, just a minute. Just a minute.
No worries.
Sorry.
Okay.
I have to, let me see.
I can also stop your screen sharing
Okay.
over
Okay,
there.
thank you. Thank you.
Yes, there you go.
Thank you. Thank you.
So Thank you. So, we've looked at how in Sunny's research, people with HIV in Zambia become very proficient narrators of all kinds of inequalities, actually, way before those were appearing in the literature. And then in Adriana's, the ways in which a history becomes a kind of resource for narrating COVID as well as HIV. So I'm going to talk about the UK part of the study, and in particular the way that people narrated future citizenships living with HIV, but also living within COVID-19. And so again, looking at people with HIV as experts in pandemics, which is the way that many characterize themselves. It wasn't only that they were characterized by this. So in this case, the findings from this part of the study, where we asked people about their resources for living with HIV and COVID together, was there were considerable resource losses, medical resource losses, even in the UK, as well as a lot of psychological stress and social isolation, and really intense increase in material precarity down to not being able to get food. I mean, people in the UK are starting from a higher resource level, clearly, than in a lower middle income country, but they were still experiencing this resource deprivation. And the narratives themselves were, as I think Adriana and Sunny were saying, resources in some ways, because people shared these narratives that they were creating about the pandemics in plural with others outside of the research, and also use those narrations as ways of theorizing the present and ways of acting within that theory for themselves. So about 12 of the participants explicitly talked about the future and what might happen next. And that's what I'm going to look at. But what I want to do, first of all, though, is look at what the kind of social philosophy of COVID-19 futures looked at this time. So for instance, at this time, some people, we could broadly say, were kind of public intellectuals, were suggesting COVID might be a kind of viral break, after which things will be better. As Arundhati Roy put it, we have the opportunity to walk through this portal into a future that we can fight for, a different future. And this was expressed in the UK. On the left, you can see the kind of hopeful COVID narratives that people produced around social care and different things. And then on the right, I've just indicated some indicative in recent empirical reports showing the futility of that hope, really. None of those things have happened. And then another kind of public intellectual position, kind of different, came from people who were a little bit more skeptical. Ashim Mbembe, for instance, who'd written for a long time about the need to transfer ownership of futures from the global majorities that currently own them, as they own futures markets, in fact, transfer those futures to other people across the planet, really. And also the need to decenter humans in those futures, something we're all pretty aware of, so that we're talking about planetary futures. In mid-2020, he started to address COVID in this kind of theorization. And actually, in his paper, which I think is very nice, The Universal Right to Breathe, suggested that what he thought at this point was that we would be addressing these questions about the future with our dying breath. So then these are social philosophers, I guess. Let's think about, oh, well, this is the futures market, which how is expressed in universities. I thought I would just show you the number of futures, marketized futures that you can see just in a few British universities at the moment. They're just everywhere. Then if you think about the more dominant mainstream futurological narratives, I think that there are a few of these. One follows a kind of teleology of hope that we can see performed in, for instance, NGOs' narratives of the upcoming ends of bad things. Many NGOs will tell you that they are fighting for the end of TB, the end of HIV, the end of modern slavery, the end of COVID. And as Greta Thunberg suggests here, where she says we don't really need so much hope, we maybe need more panic and action. This is not really a recipe for doing that much. Alternatively, quite a lot of kind of teleological narratives of the future are more tragic. What they do is kind of naturalize what is there. So, for instance, in government, UK government political and policy narratives of the normal, the return of the normal, which they introduced quite early in 2020, actually, at a time of high COVID deaths and morbidity, and shielding and failures of mitigation. And recently, the government has also deliberately stopped monitoring COVID. So in this case, what you have a kind of is a kind of normalization that basically really kind of forecloses reality. And And quite dangerously, you can see here that Eat Out to Help Out is responsible for killing large numbers of people with COVID, including disproportionate numbers of people from global majority backgrounds. And then another kind of technicist narrative that's a pretty mainstream one, I think, of the future, pursuing the future through scenarios and models. It's also quite dystopian in many ways, I think, because it kind of naturalizes again incomplete or partial or undeliverable models. And here you've got a view of modelers saying this model is not very good, but it's the best we can do. And under that circumstance, it kind of, in a sense, doesn't matter what you do. However, there are some future narratives that I think are more nearer, perhaps, to having resistant effects. And these, I think, are perhaps closer to what one might call pragmatist narratives. And Derrida's got a nice expression of what a pragmatist future looks like, which is the opening up of context. That is, within the present context, something pulls and the next step appears from context to context. So the future is really a matter of going from sentence to sentence, story to story, action to action. And in fact, I think the participants in the UK study, speaking from their background of living long-term with health uncertainties, denial, as Adriana has pointed out, stigmatization, and all these difficulties of the HIV pandemic, were narrated in this kind of way, quite cautious, constrained, but action-oriented. So the future in these cases is not really temporal, it's more like a strategic palimpsest for narrating otherwise and resistantly. That is, for creating counteracting narratives. So here, for instance, you can see Arabella exploring some possible futures in terms of lower COVID prevalence and perhaps hot weather risk reduction, and narrating that together with her COVID experience into a kind of quite short-term shift in how she might behave. Very cautious, though, Annabella here, much more cautious than what the government's narrative was asking for at this time in relation to COVID. She wasn't going out or eating out to help out. And again, here in terms of sociality, Joseph is narrating something about what kind of little steps he might make, starting online dating, maybe going out with PPE on. Angela talks about how the women in the support group she works with maybe taking some steps to do some things that they personally want to do. These are small steps that they'll take in the context of quite a large amount of risk. They're nothing like the government narratives at the time, which were, again, eat out to help out, and also go back to work and start trying to acquire more monetizable skills and higher knowledge economy type income. And none of that's appearing here. And then Joe Bloggs also here has a narration of what the normal is going to be. And unfortunately for government and policy narratives, he's not into the idea that the normal will return, or at least that it will return, but haunted by something. And that's pretty common throughout the people with HIV's narratives in this study. So finally, some participants also address the future of social and economic justice directly. Nicholas, for instance, talked about that possibility that post-COVID social care would really be recognized for the important thing that it is, and will be given paid properly and valued properly in society. And then he kind of rose back on that and says the future is uncertain again. He doesn't really know. And then after this, he talks about his grounds for optimism, though, which are very precise. His grounds are that he lives in the same community where the Grenfell Tower fire happened, and he can see people who were affected by that fire, including to some degree himself, really continuing to resist. Every week they have a demonstration, they continue to challenge the law and so on. And in fact, 2 days ago was the 6th anniversary of that fire, and everybody is still mobilized in that community. So in this case, COVID is a kind of route into a narrative of what might really be possible in the future, where he can see the future being enacted step by resistant step. So I think the UK research participants' narratives of COVID futures were much less about proper long-term futures and much more ways of theorizing the present and the near present in resistant and counteracting ways. And I'd say in that respect that these participants, who were pretty careful and acute, really, in those kind of step-by-step narrations, were pretty good, for me, narrative analysts of the futures and narrative theorists of the futures. And as the COVID inquiry is just starting in the UK, I think we'll see from that inquiry whether, you know, these participants describing the future in 2020 were right. So I'm going to stop there. Thanks so much. And then we're going to go to the South African research, I think, from Ivan. Really looking forward to hearing about this, Ivan. I've heard about it before, but it's always great. So please, do you want to share your screen and start talking about it?
Thank you so much. Let me just share my screen. And as Corinne previously alluded to, I think there is a lot of interaction between the themes that we have seen, and that those also stand to come out within the research that we did as well within the South African context. And within the South African context specifically, we were looking at lives of migrant women, specifically those who are living with HIV and AIDS within the COVID pandemic as well. And what that looked like for us entails also me to, in introducing everybody to the pandemic experts, also to talk about how they are located within South Africa. So all the participants that we had were obviously women who are migrants, specifically from African countries who were in South Africa. But the bulk of our participants emanated from a place called Dunoon, which is an informal settlement that is in Cape Town. Now, why this is important is because if anybody knows about the climate within South Africa, specifically for African migrants, it is imbued with a mobilization of anti-immigrant attitudes, and these have led to moments of xenophobia, or what I would like to term Afrophobia, where African migrants have been attacked either using words or physically in an aid to get them out of South Africa. But with how access is set up in South Africa as well, these informal settlements are the most and immediate accessible spaces that they can occupy when they go to South Africa. And for them, South Africa is that hope or that future that things might go well, as we will look at in the next few slides as well. So we spoke to 20 migrants who were either from Malawi and from Zimbabwe and living in who are living in Cape Town. And within that, we managed to collect the data using interviews, but also their narratives helped us and assisted us in understanding the complex relationships between that was an interplay between not only the different categories which they occupied, but also the different spaces and how they occupied those different spaces with the additional pandemic of COVID being put into play as well. And we used narrative analysis as well in terms of examining this. And I think as I'll talk about later on as well, it manages to weave through most of the intersections that we saw within the research in a very effortless way, and brings to silence most of the issues that were discussed within this regard. So we managed to be able to explore the women's narratives, and in terms of highlighting their experiences, and how intersectional these experiences are in terms of living in South Africa in the midst of another pandemic as a migrant woman. So their stories started to get layered in terms of most of these women may have come to South Africa and not documented by the time we spoke to them, and this also impacts the way that they have access to resources, to medication, and to social spaces as well. Some of them spoke about how they had medication from clinics, and with the pandemic requiring some sort of documentation in terms of getting medication, they also didn't have that aspect of documentation, and they didn't have access to any support of NGOs or any other companies that could help them or assist them during this time as well. And with this exploration as well, and using the lens of narrative, we begin to see different forms of power as well, in terms of interpersonal power, structural and institutional power, and how they shape the lives of these women as they are marginalized as well. And we also get to see how the issue of precarity comes to the fore, because already some of these women were working in already precarious jobs. Some of them had to wait at what was called a market. A market is just a traffic light where they stop and they can get work from there. But they didn't know where they even go to get those jobs. They would just hope for the best and get a job, maybe as a domestic worker, or to clean someone's house. And with the coming of COVID, as much as that work was a danger, it was providing for something. But with the coming of COVID, they are in a more precarious situation, as they have the COVID pandemic, but they don't have the money to sustain themselves, the money to buy food for medication, and also the ability to go to the clinic for the checkups, or sustain themselves within that regard. So the COVID pandemic and the narratives that they spoke, the way that they narrated the COVID pandemic, also stems to highlight the increased vulnerability of these women in terms of their health and their compromised immune system as well, but also on a social level, how they are continually also the vulnerability also continually increased. Now, since we are talking about migrants, it is also important to think of, okay, where did they come from? Why did they come to South Africa, and what does South Africa look like now at the time in terms of the COVID pandemic? So Faith speaks about the narrative, as she says, so I came here to South Africa. Difficulties in the situation in Zimbabwe, the situation is very bad. There is hunger in Zimbabwe. So if you are drinking these tablets, you can find out that you can have one meal between, so your health is not going to be fine. If you are drinking these tablets, your health is going to be very bad. If you are drinking these tablets, you will be hungry more and more. So in Zimbabwe, the food is there, but to get the money, there is no work, there is no everything. So you have to work hard to get one meal. So here in South Africa, it is better. So we decided to come this side, right? So aspects of poverty, of the poor economy, their health also, and this optimism that poverty will be alleviated when they come to South Africa, and the poor governance that they had back at home is left in their home country, are some of the push factors that and respective pull factors that brought them to South Africa. But through their narratives as well, we get to see that South Africa also places them in a space where they are wondering if the situation at home was actually better, since also their health is not really improving, specifically in the midst of COVID. This hope of South Africa, of being in South Africa, as much as there was hope to be in South Africa, with the coming of the COVID pandemic, their narratives also highlight that it becomes a challenge now, specifically them located as migrants who are staying in South Africa, specifically African migrants as well. Sani mentioned this assertion in terms of language and space, which is also dominant in terms of aspects of vulnerabilities of migrant women who are staying in South Africa. An example that was given within this narrative is using English. Although English is a lingua franca in South Africa, using English in clinics might have you identified as a Black person who cannot speak local languages. And that also leads people to not want to go to clinics and not want to be helped. And for some migrants, it also leads them to defaulting, as seen in this narrative by Tatenda. And within the COVID pandemic, that was also the case, because people were African migrants were given less priority in terms of being in a clinic than other nationalities. If you're more often also, if you're not documented, then you wouldn't get the service, but also the use of language as the marker to say this person is a migrant, and we have to we cannot help them within the space, increases this vulnerability of African women within South Africa, specifically the deepening vulnerability that comes with the COVID pandemic as well. And this is in addition to vulnerability to crimes resulting from the agenda and migrant status, and the vulnerability to COVID resulting from already compromised immune system and the stigma that is around their HIV status as well. She ends the narrative with using the phrase because I was a foreigner, and also the importance of that is that the word foreigner in South Africa is mobilized to apply to African migrants, whereas European migrants would be referred to as migrants or expats or anything of that sort. So that was also something that that came out in terms of showing their vulnerability on a social level, but also on a very structural level as well. So this aspect of us versus them and the politics of belonging were continually narrated within these narratives, and specifically for African migrants and these and women who are living with HIV, their position as foreigners, like I said before, this word being mobilized to describe African migrants also produces an extra layer of precarity and vulnerability and violence within South Africa. And migrants to South Africa, especially those who are economic migrants from other African countries, have been subjected to a range of xenophobic discriminations, which include physical violence, as well as they are thought of to not belong in South Africa, and as a bad as tainting the South African image, so to speak. So they are continually othered within South Africa, and during COVID that also exacerbated as well. So the other speakers also speak of this issue of mental health and the impacts that were narrated in terms of how it intensified in isolation. Also, I've spoken a lot about deepening inequalities, and specifically being a migrant in South Africa, an African migrant who is suffering from COVID, who also is exposed to COVID and distanced from the resources that South Africans and other people who might be documented access them as basic human rights as well. But COVID also has been narrated to intersect with HIV and other categories of people who are within South Africa. Specifically, if we look at the categories of nationality, migrants, and also this gender aspect that continually comes out as well. But the power of narratives also has been shown within this research, and also, as other speakers have alluded to provide value to attending to everyday narratives and conversations, and narrators and pandemic experts as primary theorizations and theories of COVID lives as well, and narratives linking COVID's local, national, and international effects for people with HIV, and also economic inequalities in terms of especially for participants doing other jobs that are odd and on 0 hours contracts or with low level benefits, with increased COVID-19 and other expenditures, and shrinking economies, savings spent, and other assets sold. Unemployment was a huge factor within the South African demographic as well, and the aspect of looming homelessness for people who are already staying in shacks or compromised households was increased within this case, and also something that came up within these narratives as well. Thank you.
Thanks so much, Ivan. That's great. I hope people are seeing this kind of the pattern of research kind of hanging together in some ways. And I think Mark's paper is going to kind of bring things together, or at least point up some of the convergences in different ways. You know, that people with HIV are pandemic experts, but then, you know, everyday narratives generally have some kinds of expertise built into them. People with HIV are definitely numerical experts, very used to dealing with numbers, which we saw a lot in these studies, I think. Yeah, Mark, let's move to your presentation about everyday lives and the story by the numbers of COVID. Thanks so much, Mark.
Yeah. Thank you for that introduction. And so my focus is really on COVID stories and really the ways in which epidemiology and modeling was used. And I want to explore the relationship between the statistical management of the pandemic and narrative, and hopefully resonating with what we've already heard about personal experience narratives. So I want to make that case, talk a little bit about, you know, how for a period of time, particularly here in Australia, but I think elsewhere, the COVID's numbers, who was infected and how many were infected, became our everyday story of COVID. Then I want to talk about how that might be a narrative, what the kind of, you know, the story of COVID's numbers traffics in narrative, ethics, and epistemology. Then I want to raise some questions about the adequacy of the COVID by numbers, you know, approach, and talk about dissensus, inequity, and power. And that's where I think there are some strong clues from what we've already heard today. And then I want to, in a kind of speculative way, and hopefully, you know, profiting from what we've already heard from other people, think about the possibilities for a reflexive pandemic futures, reflexive modeling. So for a period of time, in Australia, and these are actually from international media, you know, the kind of reflection on the sort of flattening the curve. So I've been involved in HIV and pandemics for about 35 years. And so COVID was the same and terrifyingly the same, but then strikingly different. So in HIV, I had always been used to using epidemiology to think about what was happening and to drive policy, to make arguments for you know, access to treatments and prevention resources. And swine flu in 2009-10, which I focused on quite closely, was when we started to see modeling used by epidemiologists, to kind of turning in epidemiology, which was about futures, about how to act now in the present to kind of shape what happens with a pandemic. So I think COVID brought this together in various ways, in important ways. So in Australia, we had this discourse about flattening the curve. This is a screenshot from a public video, public news item. That's our Chief Health Officer, so the most important doctor in Australia, telling us that we actually are flattening the curve. So there's something interesting here about the public attention to the kind of numbers of the virus and how that became the story. So I'm interested to think about the duality here, this storytelling about our pandemic through numbers, but also the rendering of a pandemic into numbers. It's really common to use mathematical models. So much of what we're knowing from the UNAIDS kind of, you know, global policy around 1990 and U equals U is built on the modeling that shows that lifting the number of people with HIV accessing treatment will have an impact on the future of the pandemic. We've done that with influenzas, and COVID did that very strongly. So I want to think a little bit, though, about what pandemic modeling doesn't do. And hopefully there are some connections with what people have already said about the impact of COVID on people with HIV. So the kind of superimposition of different kinds of pandemics in lives and how people are asked to cope with that in various ways. So I've got 3 arguments to make. These are not the only ones, but they're the ones that were most apparent to me when I started to think about this. The first is a lack of consensus, inequity, and power. So modeling doesn't solve all the problems. We know science doesn't do this, but what was remarkable, I guess, about COVID is that there was a kind of alterity, a kind of group of experts who didn't agree with the models used by government. And I think that's kind of a significant clue that there's something else going on in the modeling. The kind of COVID by numbers doesn't address ethical questions about how we are to live with the virus. And there are scientific questions about different ways of interpreting the models and applying them. So in Australia, we had something called AusSage, which is a group of alternative experts who came together to question the ways in which the Australian government was using modelling to plan and administer the pandemic. You had the similar thing in the UK, the Independent Sage group. I think IndieSage happened first, then AusSage kind of followed along. And I suppose what I'm interested in here is how that modelling produces its own kind of problems of knowledge and expertise and authority. It doesn't actually solve those problems. The Great Barrington Declaration versus John Snow Memorandum is another example where the GBD people were against lockdowns. So they kind of mustered scientific evidence that actually we should allow herd immunity to evolve in populations. Other groups of experts disputing whether that's actually true, scientifically viable, and that lockdowns save lives and we should use that until the vaccines are available. So I think what these kinds of tensions point to is the underlying ethical question about how we are to kind of respond to the pandemic. And what I'm questioning whether or not modelling in and of itself allows that to happen. We've heard some really strong evidence today from other panelists about what it means to live with a pandemic and multiple pandemics. So there is a kind of corpus of nuanced, richly developed, corpus of evidence about inequity and pandemics. And various people are starting to pull together that kind of alternative models about how inequity is produced by pandemics. So, Claire Bamber has done this. There are other examples. The ways in which pandemics intersect with how lives are lived in terms of exposure, transmission, susceptibility, access to treatment. So it is possible to start to think through how inequity might be factored into a pandemic. I want to ask though why these factors aren't part of our models already, and or how they can be. The kind of last critique is about power and narrative. So if models have narrative implications about how we are to live, ethical and scientific questions, then I'm wondering about power and the storytelling. And here I'm thinking, Ken Plummer's work around the politics of the story. Who gets to tell their story when, under what conditions, and who's prepared to listen to those stories? And Sean Grattan has done something similar to talk about AIDS activism in the United States and how the kind of contemporary 21st century turn in politics is asking us all to forget about the history of HIV and specifically and AIDS activism. And Sean is saying this is not just, we've got treatments now, let's move on. Sean is saying there's something political about being asked to forget, to erase from social memory the radicalism that was necessary to inspire change, and therefore how resistance was possible. And if we remember, things like TAC in Africa were born of this period about making arguments from the grassroots about how to deal with the inequities that come with pandemics, and the kind of collective basis for telling a different story, for examining narratively how we manage pandemics. Seems like it's a crucial lesson from HIV that we need to bring through into how we think about the COVID pandemic. So I suppose I want to say that pandemic modeling, even though it's highly scientized and kind of persuasive in and of itself, it renders past and futures. It is a narrative practice. However, it biologizes. It doesn't count people and lives and meaning. It counts viruses in bodies. So it both biologizes our storytelling around the pandemic and universalizes, erases the kind of situated storytelling we've already seen today. I can't really explore this, but there's a clue from, I think, Corinne's talk about futures and economic rationality that I think also, modeling comes out of economic theory and the use of models to kind of plan economies. And through the kind of critique I'm saying is that the modeling is sort of troubled because it does actually open up dissent, it glosses inequity, and in a kind of political sense, doesn't provide the basis for remembering and reflection, and therefore deliberating on the ethical dimensions of our work together. So I want to ask, how could we have modeling for pandemic futures that does these things, addresses itself in terms of dissensus, inequity, and power, can help us live more ably with the social burden of pandemics, can avoid, provide the means for political resistance, and become a kind of resource for ethical possibilities. We've heard a lot of that already, but there are other examples also in the field. So this is from the Open University group, and they've basically collected a whole lot of personal experience narratives from people living through the pandemic in the UK. So the narrative modeling is there, and I think it's about trying to to close the gap, I guess, between the COVID by numbers approach and the reflexive narrative approach to living with the virus. So thank you very much for that opportunity to share my ideas.
Thanks so much, Mark, and everybody who's
No worries.
Indeed, thank you. I think there are a few of us here who are not on the panel, so it'd be really interesting to hear your responses. If you're okay with us continuing the recording, maybe we can do that as well. Yeah, or indeed do a discussion between the panel members.
Yeah.
We're the ones up early at the moment. Yeah, so anybody want to come off mic and ask questions or come in, would be very welcome. I'm talking to the panel members here too, rather than Aphrodite, who may not feel like being the sole representation of audience here.
I'll start. I think from all the narratives that from all the papers that we have seen, also, like, there is always this question of narratives requiring people, but also having a great way of having people open up their lives and being able to show different aspects of their lives, But the question that I had, and that I also, it's a thinking that I've always had, but I also wanted to know what other panel members think about it in terms of their papers as well. Now, there is a point where in research we reached, specifically with this paper, I also reached a point where I had a now what moment, specifically also a now what moment that also speaks to returning back to the participants in terms of they have shared their narratives with us. Now, what do we do in terms of aiding them, specifically if you know that this person is in such a situation? And for some of them, after we were done with interviews, they also asked, oh, so now what? Are we going to get help? Is something going to get better? You know, which is a question that I always ask. And I just wanted to know how other panel members, first of all, deal with that, but also think about that in terms of the future of research and narratives.
So my thought about this, just in terms of a little bit what Mark was saying, is that in some ways you can see this kind of narrative evidencing and making a difference quite well in COVID. I mean, particularly the example in the UK is long COVID, where people just gathered together thousands of case studies around long COVID, and a little bit depended on who brought those case studies. Medical professionals bringing them were the most powerful. But it was really entirely out of that witnessing that something happened around long COVID clinics, the recognition of long COVID and so on. I mean, that may be not what happens in the South African example either, but I mean, it was kind of interesting that the participants in the UK knew that this kind of accretion of lives could make a difference. And in fact, quite a lot of them, we opened up this thing that if you want to blog about this, we've got a blog and people are blogging about it. So it's talking again, but you know, people can see that talking can make action in some ways. And that's a small example.
I get asked that question a lot. Like, so what? You've got the stories. What happens next? It's a really good question. I don't know. Maybe, you know, taking the book out of IndieSage and AusSage, a kind of stronger promotion of the kind of narrative-based ideas using media, and trying to influence policymakers. Yeah, I mean, it's kind of multi-layered. I try and promote social research here in Australia around pandemics and try to know who the policy people are, and hopefully I'll be invited to come and talk about the work. Do you know what I mean? It's sort of like when the door opens, be ready to act. I think create alliances. So I'm doing work around LGBT communities and data medicine and trust, disclosure. So working with all the peak agencies at the very outset to design the research so that everyone is, you know, everyone believes in what I say, and will take up the ideas, and in ensuring that what we look at actually will make sense for people working in the field. So trying to, I guess, more of a collaborative research approach. Narrative can't do everything. You kind of have to be a pluralist methodologically, I think. Also, I don't know, I'm speaking out of turn at a narrative conference, but I think that there's, you know, the co-design push, cultural safety, there are models around to help, I think.
There's a great paper by Rochelle Burgess suggesting how you can start small with this. You know, like you start small, you do something that involves people, and then at the other end, where you have the kind of money and the resources, you do the most that you can. I think that's a nice. That's kind of a nice paper, because it takes the feeling of you have to do everything off of you. You can look at it and think, okay, I'm at this point, I can do my small thing at this point. Yeah. I don't know what you think, Sunny and Adriana, about, you know, how your work.
Yeah, so for the Zambian case, I think Ivan raises a very important question. And I think it's been across all the research projects or works that I've been involved in, where people ask you, so what's the end game? You know, what next after this? You know, interestingly, for some of the participants within this group, they were sort of very positive and encouraged by the fact that someone had some time to talk to them. So especially that it was a period of silence and just being, isolated. So there was a sense of appreciation to some level that, some people still think about us, and this collective way of, generalizing and looking at those that are living with HIV and say there are people who still think about us. So by you calling, I feel empowered, I feel encouraged. So it was more of an appreciation as opposed to looking at it in a form of this person is coming with solutions, or this researcher has some answers to some of the problems that we're going through. But definitely they were interested in knowing the direction in which things were going to be going after the research. Are you going to make recommendations to the government? Are things going to change? So, but yeah, on a very simplistic way of looking at things, I think a lot of these studies participants were empowered, and they saw it as an opportunity of having to share their stories. That in itself acted as a form of relief from the mental stress that they were going through.
Adriana, do you want to comment?
Well, about as I said, a lot of them were activists for a long time, and they interrupted this kind of actions during the Bolsonaro government. Things become difficult to have a research to be together, like transport and places to reunions and etc. So the encounters we have was like an opportunity to they reunited, and we planned to make things together with an event to share what we built during the encounters. We had intentions to turn in new actions to get together, because they said a lot about it, because we have the encounters to make the maps. So it was an opportunity to start again the work that they couldn't do at that moment. But just for the pandemic, because of the pandemic, things weren't possible to continue. So I think they could make new bonds with the people they don't know, because a part of them were knew each other for a long time from their activism, but there are a part that was new people, and this new made the opportunity to have the support. They talked about this at the end of the encounters, and in some interviews this appears too. So I don't know if it's an answer, but it's what happened.
I think it's really interesting if you look at these different studies that the kind of knowledge that people were expressing in 2020 was so prescient, narratively expressed knowledge. You know, that people in Zambia knew already what the pattern of funding was going to look like when donors responded to COVID. They knew that there would be retrenchments in HIV funding and that there would be consequences. And they were so highly aware, super aware at that moment of what the structural inequalities were going to play out like. You know, that's no comfort to people now or something, but you know, it certainly points to how important that knowledge was. Or that in Brazil, people knew already what their kind of historical strengths were, and you know, that actually did play out in the way that the history of vaccine activism was maintained in Brazil. The vaccine program was amazingly successful despite Bolsonaro, really. And then in South Africa and Brazil, I mean, both, South Africa and Zambia, you know, actually people's people's public health knowledge, general public health knowledge, had a very good effect on COVID, even in South Africa. I mean, the later waves came, but the early and most damaging COVID wave was really not as destructive as people had thought. You know, which is really a kind of strong evidence of what kind of public health abilities people were living with, abilities that were totally absent in the UK. Totally absent. People knew a lot, and people with HIV knew a lot. And I think in their case, you can see how that kind of caution in the stories is probably going to be vindicated from what we can see about the public inquiry that is now underway. You know, that is probably going to say quite a lot of the similar things that they were saying in 2020. I don't know, that case of those women who are African migrants in South Africa are just are in such a multiply disadvantaged and marginalized situation. You know, it's just, I can see that people, those were the group, those women had no NGO, did they? They had no representation in that way. It's no wonder that they probably want Ivan and others to go back and, I don't know, help generate an NGO or make real change that is going to, you know.
Yeah, there is those layers, and also there are help sometimes with one specific. So it's also within this research and also my own research, where within my own research, I also went there to do interviews with resources to help them with aspects of violence, as if they need documentation and all those other factors, you know. But yeah, it always, although I also agree with Sunny, there was that cathartic moment where they said, oh, it was actually helpful to discuss with someone about these aspects, and to have a space to just talk about them and have that space, you know. But it just begs the question of, okay, so what else can we do specifically, because there are multi-layers like this, and there are so many things that can be responded to, some of which are not even within our capacity as researchers as well, but also it just, like, a lot we can do with that knowledge that is presented to just have an impact of on people's lives than what we usually do in research, in terms of taking and not really doing much about the knowledge, except for it being beneficial to ourselves.
Corinne, just to say, even with complete vulnerability from these participants, I think their stories have the power to sort of create change and to even foster connection that in a way would help them overcome the challenges. So if there's a way or a platform where these people who we talk to, who share their stories with us, can be given you know, an opportunity to make those connections. I remember the resource constraint research that we did, where we brought in people from different NGOs who are living with HIV. I could see the connection that was created as a result of that platform. But of course, that can be different with COVID. So to some level, again, it's using these stories to create change, but also more importantly, is to use these stories to foster connections amongst these people that are vulnerable, and in a way lead them to a place of overcoming some of these negative aspects that we've been you know, discussing on this forum.
Ivan, do you think that is anything that would apply to the women that you were talking to? Were they already connected? Were they already?
So that's one of the things that they mentioned, but also their connections are really limited to the people that they meet within clinics, and the people that they meet through those channels. They have a few WhatsApp groups, but no formal connections that actually, or networks that actually empower them in a way, or in a sense that Sunny is talking about, you know, because none of them were connected, like you said, Corinne, to NGOs. They didn't even know they could access NGOs, or where they could even find that information or those resources that are powerful in terms of stating where, like, what rights do they have to getting medical medication. What some of them didn't even know about the clinics that they could get medication from, especially during COVID. So their networks also are not generating enough information to empower them, but also they also know that as migrants, maybe it's like they feel undeserving of even having those resources that are basic human rights for everybody, whether they are documented or undocumented. So yeah, not really connected to the more powerful networks that can really have an effect or impact on their lives.
It's kind of something that links to what Mark said, that, you know, you can, even as researchers, you know, you have limited access to other networks. And you know, it used to be also something that happened a lot around HIV. I think that people had their own networks that were very supportive and sustaining among themselves, but then they couldn't reach to that next level. And you know, to like bridging capital, as Putnam would call it, you couldn't reach to that next level where decisions were made and resources were allocated. You couldn't get to that. But I know Ivan's been having some discussions with other activists around different kinds of resource issues, like the people from MCSJ and stuff, that are kind of making links between African migrants and South African people themselves. But that might be, maybe that's one way, Ivan, to build connections.
Yeah, it surely is, specifically the conversation with MCSJ in terms of documentations and what they are doing in terms of aligning that. So I think that gap needs to be closed in terms of migrants who are undocumented, and also this group of migrants who are living with HIV, making a connection with such communities so that they can be empowered in terms of getting these resources and access to the resources that they need being in South Africa as well. So very helpful as well.
It does remind me of the very early HIV, sorry to be old, but the very early HIV research was about actually finding out how to reach people. So injecting drug users living on the streets and sex workers and non-gay identifying homosexually active men. The social knowledge that needs to be acquired to actually reach and connect and talk and find out what these people need or don't need was making change. So the very fact that you're kind of reaching out to the women in Cape Town is sort of creating a new, I don't know, a new way of a kind of new social form, really, through the research. It's kind of action research. Is that too romanticized? Am I kind of?
I think it's solution oriented as well, in the sense that if you're reaching with the point to make change and not only understand, I think it's a solution focused approach. It also brings I don't know what answer it brings, but it also brings a response to say, okay, we are starting this project, but at the end goal for the people is also this aspect, you know. I think it's a good way to think about research, if it doesn't limit the fact that if we don't have that solution, are we going to stop the research, you know? So yeah, just thinking out loud.
Yeah, and the medical people that I work with, they're all about, they want to know what the solution is all the time. And sometimes you can't have that answer, yeah, like that in the way they think about solutions, which is drugs and behavior change and so on, and education. So I don't know, maybe we just need to get better at recognizing what we do as having the kind of social impact that it does.
I think we're going to need to close, because Titi has to close the meeting. I don't know if anybody, Adriana or Sandy, do you want to come in again before we go?
Yeah, just maybe to say, it's also particularly the dissemination of these stories, how we share them, where we share them, and with who. I know that in many cases, there's always this, we take the academic platforms and share some of these issues, which actually would influence policy direction. and how things are done. So the link between the actual practice, the practitioners themselves, and people in academia, I think we should be bridging that gap so that perhaps this would be beneficial. I know that they wouldn't come to us as academicians, but it would also be good to sort of find opportunities or platforms where some of these ideas from an academic point of view can be shared so that if there's an effect, it starts from the top, particularly in the case of Zambia. I think policy direction mainly is shaped by evidence now that we have a new government. At least there's that direction of using evidence as a way of making decisions that affect people at the national level. So maybe just to add to what Ivan was saying, we might as well want to be stepping in on events, programs that involve decision or policy makers, so that these ideas are shared. Why should it be 6 months for someone to go and collect their medicines? And this can only be changed if we share these findings with a district health director or a minister of health. So dissemination also will play a key role, not just among us ourselves as academicians, as Elia mentioned, but just even practitioners as a whole. Thank you, Corey.
Thank you. Adriana, do you want to say anything before we close?
Well, I think it would be nice if the people that are people like the participants could be at the university with us, showing the point of views and sharing new knowledge with us and pointing some directions, because we have there are things that we can see and maybe they can't, and the opposite is true too. So I think we must work in this direction, to share more. Only since the beginning of the studies, if possible.
Yeah.
To the distance sometimes people say they feeling between the academical and everyday life.
Great suggestions. It's a lot of work, but it's all worth doing. Thank you. I think we have to close. Titi, thanks so much. Do you want to close the meeting now for
Okay.
Yeah,
Okay.
thank you.
Thank you.
Yes, thank you.
Thanks, everyone. Thanks for organising this.
Thank you.
everybody.
Thank you. Bye-bye.
Bye.
Good luck.